Welcome, everyone. I am Sherry Evans, a co-chair of the Postpartum Hemorrhage Community of Practice, and I'm very pleased to present this webinar with you today. Our facilitator this afternoon, will be Dr. Andrew Weeks. Andrew, let me turn it over to you.
Okay, thanks very much, Sherry. So I'm Andrew Weeks. I'm an obstetrician in Liverpool with a long-standing interest in postpartum hemorrhage, and I'm part of the steering committee of the PPH community of practice. So maybe we can take the first, let me progress on the slides if I can. There we go. Okie doke. So that's me there. So I think there's maybe nobody who's missed seeing all the developments on postpartum hemorrhage over the last year or so. It's been fascinating, actually. We had a big PPH summit led by WHO back in March. And out of that, this is last month, came the roadmap to combat postpartum hemorrhage, recognizing that it's a major problem and which really needs addressing, and the inroads into it haven't been as much as we would like. And so within that roadmap, there's, of course, the postpartum hemorrhage community of practice is actually about practice. It's about people trying to get together who are the practitioners on the ground and the people who are trying to implement. You've got all the research going on, but this group specifically is about how do we implement it? How do we move forward? How do we put into practice what we know is good? And if you look within the WHO roadmap, and they give key activities and milestones for the implementation, well, you can see the sections here. Now, let me see if I can get my laser up. How's that? So you can see the sections here. I hope many of you are involved in national health policy and leadership, but there's these sections of procurement and supply chain, staffing and training, equity and access to care, women's rights. They all need addressing. These are key parts of getting implementing the improvements in care. And yet you'll notice that, of course, the procurement and supply chain, actually, that's largely about drugs. It's about getting the right medication to the right place, getting the right devices, getting the right equipment there, and getting a cold chain as well for those drugs which need to be kept cold. Staffing and training are key to that. But actually, if you look at the manual methods, which is our particular talk today, actually, if you've got methods which just need your hands, then you don't need that procurement and supply chain. What you do need is the people in place and them to be trained, and to be trained in those methods. And of course, if you've got good training and you've got those staff where who are trained in ways of maybe first aid for postpartum hemorrhage or in good compression techniques, then that should indeed improve equity and access to care, because no longer do you need people to be told to go and buy drugs from the local pharmacy. It won't rely on making sure there's no stockouts. So that's what we're talking about today. We're trying to talk about these manual methods as opposed to the pharmacological methods. Now, if we go, I teach students in Liverpool about postpartum hemorrhage, both undergraduates and postgraduates. And this is a flow chart which I commonly use to explain the processes of how things go on. And of course, I'm updating this all the time. You'll see this has now got the emotive bundle. And in fact, we've got our next webinar is the emotive, is specifically related to the results of the emotive study, and that's on the 14th of July. But if you look at how this works, you've got prophylaxis with medication, measuring blood loss at all births, and those who have excessive blood loss, well, then you've got these are the treatments on this side. This is ongoing blood loss as the blood loss gets more and more, and then there's assessments and resuscitations So you've got the first line stuff that you do right at the top here, and you'll see that a lot of these are drug related. A lot of them are pharmacological, whether it's tranexamic acid or oxytocin, ergometrin, carbaprost. And it's really only after that that you move on to the manual techniques. And that depends, of course, on what the problem is, on the underlying problem. So these are universal for anybody with a PPH. But then once you've got, if you know it's a retained placenta, then you need to work out which manual technique is necessary. So aortic compression, particularly useful in this situation, but manual removal. If, of course, it's during cesarean section, whilst you may have used this as first line, actually then you move on to surgical treatments during the cesarean section, or if it's vaginal birth, there's other manual techniques, balloon tamponade, of course, being specifically useful in that before you move on to laparotomy and using the same things. So what you'll notice is, of course, that those ones which I've highlighted here, the manual techniques, are those, they tend to be the second line. They're either for the first aid, where you've got here where there's sudden massive hemorrhage, and so those you bring in very quickly, but otherwise they tend to be second stage techniques. And that's why when I'm teaching my students, I give them this sort of rule of thumb, which is that oxytocics prevent morbidity. They do reduce blood loss. They're highly effective at reducing the amount of bleeding that people get. Do they reduce mortality? I mean, how often in a maternal mortality review meeting do you say, if only we'd given oxytocin rather than ergometrin, or the other way around, or if only we'd given 2 doses of oxytocin rather than 1. Well, it gets beyond that, doesn't it? Those are the first line things. And it comes down, when it's trying to prevent death, it comes down to services rather than the use of oxytocics. And that means services include not only having the right staff to take people to theatre, having them well trained, having blood transfusion services, having emergency transport. And a lot of the devices come into that second stage, and a lot of the manual techniques. So it's the manual techniques that we're going to concentrate on today. If I can. Of course, in the UK, if you look at my own country, in the UK, we did some analysis a few years back of maternal deaths in the UK. And you can see that actually the vast majority of our improvement, our reduction in maternal deaths, came long before oxytocin and ergometrin were available. So this is a chart. This goes back to 1850. So this is really very historical. This is now 170 years ago, back in the UK. And you can see here the maternal mortality ratio. This is maternal mortalities from hemorrhage overall. So that's not dissimilar to some of the places around the world. This equates to maybe maternal mortality ratio of 400 or 500. And you can see it was very much around that level in the UK. This was when hand washing and infection was first recognized. Modern cesareans were only described in 1882. Midwifery started to come in here. Still no oxytocin, ergometrin, prostaglandins, none of that. But ergometrin was first recognized. Here we go, 1953. Already the rates of death from hemorrhage and postpartum hemorrhage, which is the one in blue here, are already reducing. And this is before blood transfusions. Blood transfusions come in the Second World War, along with universal free healthcare with the National Health Service. And actually, when does active management of the third stage come in? Well, really, it comes in routinely around in the 80s, something like that. But oxytocin synthesized. They had a bit of pituitary extract, but this is the 1950s. So from a historical perspective point of view, in the UK at least, we recognize very much that postpartum hemorrhages is about getting the services right, not just getting the exact drugs. We've concentrated on the drugs because we've been evidence-based, and they're far easier to do randomized trials in. Device trials and manual technique trials are very difficult. So although we've concentrated on that, actually we'll find a lot of the mortality reducing through the use of improved services. And certainly training and good staffing come into that. So moving on, this is I just wanted to give that brief introduction as to why we're looking particularly at manual techniques. But we've got a fascinating range of techniques to describe in the next hour and a half. These are UK times, so I'm sure wherever you are in the world, it'll be a little bit different for you. But we've got, and I should apologize in advance if your favorite technique isn't there. I think we all have our own favorites that we champion and that we sort of drive forward with and we're encouraging, and we've just taken a selection here, and if you want to suggest other techniques that you want us to concentrate in future webinars, be delighted to, but we've taken an interesting selection here. So I think Justus Hofmeyr, people will know very well, who's going to join us from South Africa. He's an obstetrician, clinician, and really he's been at the forefront of developing clinical evidence and RCTs and innovations for the last, 30 years or so, Justus. So we're delighted that he's joining us today to give us an overview of the uterine compression techniques. We'll then move on to aortic compression. Now, Greta Heitmann is joining us from Norway. She's a Norwegian anaesthetist, and we're delighted to have her here. She's an obstetric anaesthetist in southern Norway and editor of the National Guidelines in Obstetric Anesthesia. But she's really been championing over the last few years aortic compression, feeling, I think probably rightly, that this is an underused technique, which is simple. And she'll tell us more about what she's doing with that. And then thirdly, we have Josephat Byamugisha, who's going to talk us through intra-aortic balloons, which is interesting because it's a different way of doing the aortic compression, but this REBOA technique people may not be very familiar with. But Josephat is a professor at Obs and Gynae in Malaga Women's Referral Hospital in Kampala. And he's been at the front line of the fight against maternal mortality, both in Uganda and around the world for the last 20 years. But he's principal investigator for a new study which is taking place at the moment, looking at the REBOA technique and whether actually it saves women's lives, women attending Malaga in severe conditions, shock from extreme hemorrhage. And so he'll tell us a little bit more about that later on. What we'll do is we'll have about 15 minutes of each talk, and then I'll take questions after that. If you want to put the questions either in the chat, or if you want to put the questions by raising your hand and you want to speak, then either of those are acceptable. So without any further ado, let's move on to Justus, who's going to talk us through uterine compression techniques. Thank you, Justus.
Well, hello everyone, and thank you so much for this opportunity to speak briefly about uterine compression techniques. I do have a conflict of interest relating to the maternal tray for monitoring blood loss, but that is not a topic of this discussion today. Here we go. There's a delay on the thing, so I've gone further forward than I should have. I'm going to go back here. So the outline, I'm going to show that there is some dissonance between recommendations and evidence related to compression techniques, and then go through uterine massage, bimanual compression, butterfly compression, lower segment compression, balloon tamponade, vacuum tamponade, at cesarean compression sutures and the uterine tourniquet, and then one slide on research at the end. And I think we're all aware that the major mechanism of hemostasis of the placental site is the contraction and retraction of uterine muscles, which physically close off the perforating arterioles supplying blood to the placenta. And many of these compression mechanisms are attempting to support that mechanism in addition to applying direct pressure at the site of bleeding. Sorry, we're going the wrong way. So A recent comprehensive review of guidelines of various medical societies found that really all these guidelines recommend uterine massage, bimanual uterine compression, and when these fail, intrauterine balloon tamponade or other surgical interventions. So there's very consistent recommendation of all these compressive measures, both for vaginal birth and at cesarean birth. However, when Andrew Weeks's group did a Cochrane review and looked for evidence on any of these mechanical and surgical interventions, there was very, very little to be found. 9 small trials, low to very low certainty. For external uterine compression, there was an unclear effect on blood transfusion. And in fact, the only, shall we say, significant results in any of these trials was to do with balloon tamponade, where the evidence available suggested that balloon tamponade, and this was balloon tamponade with a condom balloon, increased blood loss rather than reducing it. So there's a big disconnect between what we recommend and what we have evidence for. But we can't be nihilistic. We need to continue practicing with what we have. So we're going to discuss these various methods. So uterine massage is recommended by WHO both for prevention and for treatment of postpartum hemorrhage. It is included in the emotive bundle of treatment as published in last month in the NEJM. If one looks directly for evidence, then in terms of prevention of PPH at vaginal birth, a review found that there was insufficient evidence, and similarly for prevention of PPH at cesarean section, there was insufficient evidence of effectiveness. So we don't really have the evidence. However, uterine massage remains something which is quite intuitive. There's no evidence that it's harmful. It may be uncomfortable for the mother, which is important to keep in mind, but is generally recommended both for prevention and for initial treatment of postpartum hemorrhage. Bimanual compression, and by this we're talking about compressing the uterus between 2 hands. So if one's right-handed, the right fist is placed through the vagina into the anterior fornix, and the left hand is used to compress the uterine fundus against the internal right hand and maintain pressure, which is very tiring indeed, while other methods of treatment are coming into play. It's certainly intuitive in that it follows the general surgical principle we have that when there's bleeding, apply pressure at the point of bleeding. So this is direct pressure applied to the uterus. And I think it's very important as a first aid procedure, because when you have nothing else, this is the one thing that you can do. So if you're in the middle of nowhere and someone has given birth and they're bleeding, the one thing you can do is bimanual pressure. And I always say, just ask for a condom, because my experience is that whenever you're in a group of more than 4 or 5 people, someone will have a condom. You ask for a condom, you put the condom over your right hand, you use that hand to do the internal pressure, your other hand to do the other pressure, and you need nothing else to maintain pressure on that uterus until such time as help can come. So although we don't have direct evidence of effectiveness, in terms of general surgical principles, this would be our first aid intervention that we can do when we have nothing else, no drips, no drugs, no anything else. Andrew's group have or are working on a device to try to improve the efficiency of bimanual compression. And if you look at on the left-hand side, the device is in its flattened form, and it's introduced into the vagina. The leading point is on the left, and then once it's in the vagina, the 2 handhold grips are pulled into alignment with each other, which causes the leading edge to form into a platform at right angles, which goes into the anterior fornix, as you can see on the illustration, exactly in the position that one's fist would for bimanual compression, and then that's used as a platform against which to compress the uterus. very interesting concept, which I've really only seen talked about by one group, the Chantripatak's group, and they've done 2 trials. One was a large trial for prevention where they showed that this was statistically significantly effective for prevention. And this trial with only 120 patients where this technique was used for treatment of postpartum hemorrhage, and they found a significant small reduction in blood loss. So what this is single-handed compression of the lower uterine segment transabdominally just above the symphysis pubis. And I find this quite an intuitively attractive method, because when you think of it, what you're doing in the lower segment is actually compressing the blood supply from the uterine vasculature to the lower segment of the uterus. And also compression of the lower uterine segment may stimulate release of prostaglandins. And so it's certainly something which intuitively could be an effective method, and which I believe warrants further research. And then balloon tamponade, of course, has been a huge issue over the last few decades. It is still recommended by WHO, although with some reservations. What we do know that from the 2 randomized trials, one individually randomized and one large randomized trial where the centers were randomized, both of those trials found that the group allocated to condom balloon tamponade did worse than the control group. And there are many reasons that people have argued that this may have been the case. So we need to think a little bit beyond balloon tamponade as we know it, and think of what other options are there. The common usage of balloon tamponade employs a fixed volume of fluid in an intrauterine balloon, which then maintains that volume, which in a way is a bit counterintuitive, because one would like the uterus to be able to contract, and that may prevent contraction. So one thing we've looked at over, in fact, several decades is a kind of balloon, and originally we just used a glove, which we felt made a much better shaped balloon than a condom. So we used to use a balloon made of a surgical glove, but instead of putting a fixed volume of fluid into it, we attached it to a giving set with a liter of saline, which was suspended above the patient. And this maintained a fixed pressure inside the uterus, but allowed fluid to move in and out of the balloon as the uterus contracted and expanded. And this seemed to us to be a more physiological way of applying balloon tamponade. And this did lead to the development of the Alavi uterine balloon tamponade system, which has an intrauterine balloon with a fluid reservoir suspended above the patient, so that as the uterus contracted, the fluid moves back out of the balloon, and as it relaxes, more fluid moves into the balloon, maintaining that fixed pressure rather than a fixed volume. The other alternative to uterine balloon tamponade, which is now becoming much more, shall we say, gaining a lot of interest today, is rather than applying a compression force from inside the uterus, to apply a suction force to suck the uterus down. So it's a negative pressure type of uterine compression. And the best known device is the Jada device. It was previously called the InPress device, and 2 observational studies found very high rates of its ability to stop bleeding. Having said that, all the balloon tamponade studies that were uncontrolled also found very high rates of bleeding stopping when the balloon was introduced. So, observational studies are not really evidence of effectiveness. Nevertheless, on the basis of these studies, the Jada device has been approved by the FDA, and according to my colleagues in North America, is becoming the standard of care in North America. The balloon tamponade appears to be disappearing from use in favor of suction tamponade. Of course, the Jada device is unaffordable to those of us working in low-income countries. So what we've, oh, sorry, that's just the next picture of the JADA device. So what we've been using for many years is a simple Levine stomach tube, anything between a 24 and 36 gauge tube. The JADA device, I believe, costs $1,200 US. The Levine tube costs 0.50 US cents. So there's quite a big cost differential. And we've done several small acceptability studies, case reports, and this is proving to be certainly in terms of experience, a very efficient way of applying intrauterine tamponade. So the balloon catheter is simply inserted into the uterus. A suction of around 100 millimeters of mercury is applied. So it's a fairly low suction. And our experience, as everyone's experience has been with balloons and everything else that's tried, is that whenever one puts a catheter in, applies suction, the bleeding stops. And I just say that with a smile because it's not evidence of effectiveness. What comparisons do we have so far between suction and balloon? Because to me, this is the critical question. If we're going to use tamponade, should we be using suction or should we be using balloon? They are two completely different. It's two completely different approaches. So there's been one non-randomized comparative study published this year where historical use of the JADA device was compared with historical use of the Bacri balloon tamponade. So that's a purpose-designed intrauterine balloon tamponade. And the outcome that was looked at was the need for massive transfusion. And looking at the data to date, the need for massive transfusion with Bacri balloon was 21%, and with JADA device was 3%. So keeping in mind the lack of robustness of this methodology, the results certainly favored the JADA device. We were conducting a randomized trial of balloon versus suction tamponade in South Africa, 10 sites, and after a year, our recruitment suddenly stopped. And when we tried to find out why, we found that the providers at the sites, after having experience of uterine tamponade, were very reluctant to randomize clients to balloon versus suction, because their experience was that suction tamponade seemed to work better. And we conducted an anonymous survey of 23 providers at the site who had used both. And on all of the categories that we asked them about, ease of insertion, comfort for the patient, effectiveness, speed of action, all of these, they significantly preferred suction to balloon. And in terms of which method they would prefer to use, in general, 78% said they would prefer to use suction, and 22% said they would prefer to use the balloon. Balloon had been the standard of care in all of these hospitals for many years prior to the study at which suction was introduced. So that's all we have so far in terms of comparative studies looking at balloon versus suction. Let's move on briefly in a minute or two to what we can do at cesarean section. Compression sutures were popularized by B. Lynch probably 2 or more decades ago. And now there are more descriptions of compression sutures, I think, than one can count. And everyone has developed their own system, and particularly for lower uterine bleeding following placenta previa. But the truth is we don't have robust evidence of effectiveness of any of these. There's some evidence that the modified B. Lynch may be somewhat more effective than the original B. Lynch, but again, that's not showing whether either of those is effective compared with no intervention. So we all use these compression sutures, but don't have good evidence of their effectiveness. And I'd just like to mention uterine tourniquet with a Foley catheter. This is something that certainly in practice we use very often indeed, particularly in rural settings where there's not the expertise to do hysterectomy. And we advise our junior doctors often newly qualified doctors who are doing cesarean section and are faced with massive hemorrhage. One can very quickly just loop a Foley catheter around the lower part of the uterus, cross it over, pull it as tightly as possible, put a clamp on the site, and all the blood flow to the uterus is immediately stopped. And that gives time to resuscitate the patient, to call for help. And if there's no help at hand, the tourniquet is just left in place, the patient closed and referred to a hospital where she can be reopened and appropriate management given. It was always taught that the tourniquet could be left inside for a long time, but I would like to alert people to the fact that recently we have had 2 cases in South Africa where the tourniquet was left for more than 24 hours, and there was uterine and in one case ovarian necrosis. So we wouldn't recommend leaving it for more than 4 hours. And so the last slide, what important research is ongoing? One of the most important trials at the moment is the WHO RED trial, in which there are 4 arms. The one is a fixed, and this is for postpartum hemorrhage after vaginal birth, unresponsive to first-line treatment, and they randomized to the fixed volume LRV balloon, a free flow LRV balloon, the suction tube tamponade using the cheap Levin tube, or current care, which in the sites was a large Foley balloon. So I think that's the last slide. Thank you very much. And I would be very happy to entertain any questions. Thank you, Andrew.
Fantastic. Thanks for that authoritative overview, Justus. That's wonderful. Right, questions. We've got a few minutes for questions. Who's got questions for Justus? Please either put up your hand, or can you put up hands on here? No, you can't put up hands. Maybe you've got to put it in.
I see something in the chat.
Hang on, here we go. There's a Q&A.
Oh,
okay.
Oh, sorry. No, it's just asking for a recording. Sorry,
Let's
it's just asking
have a look.
And there's a second
okay, here's a juicy one for you, Justus.
Poorly evidence intervals. Okay.
This is a juicy one for you. Do you think we should be using? Do you think we should be using poorly evidenced interventions for PPH when there are others available with robust evidence?
Right. Thank you.
The challenge will be sorting out which is which.
Yes. So most of what we have robust evidence for is prevention of postpartum hemorrhage. So we have good evidence that oxytocics make a difference. We have evidence that misoprostol makes a very small difference, but is much, much worse than other oxytocics, such as carbetocin or oxytocin or ergometrin, and has more side effects. And a lot of that evidence has been just applied to treatment of postpartum hemorrhage. The number of trials for treatment of postpartum hemorrhage are very few. There's some for first-line treatment, and as you know, there's some big trials. The big WHO trial looking at misoprostol, for example, for treatment of postpartum hemorrhage, showed absolutely no impact in patients who'd already received oxytocin, 0 effect. But the rest of the interventions that we use for treatment, particularly for refractory postpartum hemorrhage, we really don't have robust evidence. I would love the attendee to perhaps type in the chat. Okay, I'm reading now. Okay, tranexamic acid, okay, for PPH prevention, yes. Okay, so today we're not talking about tranexamic acid, but of course there is strong evidence of the effectiveness of tranexamic acid for treatment of postpartum hemorrhage at vaginal birth, the woman trial, which showed reduction in mortality from hemorrhage, although it was a kind of a post hoc analysis which was done to show that. There have been numerous trials showing that tranexamic acid is effective for reducing blood loss when used prophylactically at cesarean section. However, the biggest trial, the most recent trial, which actually I think had 11,000 cases, which was more than all the trials before, did not show a significant reduction in blood loss with prophylactic use of tranexamic acid at cesarean section. And if I may take just one moment to say what I think is a very important thing. Please be very, very, very cautious with the use of tranexamic acid at cesarean section, because in many theatres, I know tranexamic acid is now being used routinely for every cesarean section. I think our latest evidence shows that it shouldn't be routine, but it certainly should be used when there is excessive hemorrhage. But the big danger of having tranexamic acid in our theatres is that the tranexamic acid million parents to bupivacaine. And we now know of 6 mothers in Southern Africa who, healthy young women having a cesarean section, who've died from intrathecal tranexamic acid administration. Most unfortunately, tranexamic acid is intensely neurotoxic. And I've dealt with some of these cases, and it's a most traumatic thing. The woman is given the spinal, she lies down, and within a few minutes, she begins clonic procedure. She loses consciousness, and 80% die very quickly with this. So it's a huge risk. And when I speak to colleagues in other low middle income countries, all of them say to me, yes, they know of a case who has died from tranexamic acid being given instead of bupivacaine for the spinal. I went off at a tangent, but thank you for that comment. I accept we have evidence on tranexamic acid, and I'm not suggesting we should use compressive measures to the exclusion of tranexamic acid. It would usually be one of the things that we've already given and the patient's still bleeding, and we go on to compressive methods. Thank you.
Thanks very much, Justice. I mean, it's one of the eternal problems with PPH, isn't it? What do we do when the evidence actually isn't strong? Because there's so much clinical expertise. We've also got good observational studies, but the trouble is you can't put in an observational, you can't put in a technique in an observational way without putting the resources around it. So you're automatically sort of biasing it. So it's one of the troubles that we constantly deal with with these device trials. I think we should move on. Thank you so much, Justice. There is opportunity to type answers, I think, in the question and answers. So if you've got the time or the interest, then people can follow those. Okay, so let's move on. Greta Heichmann, thank you very much for coming and speaking with us this afternoon, telling us a little bit about external aortic compression, which seems to be somehow a forgotten technique, and I suspect you're going to argue shouldn't have been forgotten, but I'll leave that to you to share with us. Greta.
Thank you, Andrea, and thank you so much for the opportunity to talk today. As Andrew pointed out, I'm a Norwegian anesthesiologist, and a few years ago, I had a chance to take a specialization in obstetric anesthesia. As a part of this, I worked in Sweden, and at the university hospital in Sweden, I had a new experience because the patients that I received in the OR suffering from postpartum hemorrhage were more circulatory stable in Sweden than my experience had been in Norway. As a part of my specialization, I also visited Malawi and north of Brazil. And after seeing how the challenges are when you work to save women in settings with limited resources, I started this project to implement and teach external aortic compression. And as a part of this, I have, with support from Innovation Norway, developed a trainer for healthcare workers to practice on external aortic compression and uterine massage, and also a couple of devices. And that is my conflict of interest. Today, I'm going to walk you through what is external aortic compression and what is the evidence and the reason why we want to recommend it. How do we do it? And I will also share some of the research that we have been doing. As we know, the blood vessels that supply the uterus and birth canal originate from below the division of aorta. And, oh, sorry about that. I was just trying to get my pointer, but it is not working. So if we clamp aorta it is logic that the bleeding will be reduced or stopped, independent of the cause of bleeding. What we do when we perform external aortic compression is not a clamping. We press aorta against the spinal column using our fists as shown here, or we could also use our fingertips. And by this maneuver, aorta is pressed against the spinal column and the blood flow is reduced or stopped. And by this also the bleeding. When we do this, we reduces the bleeding, and by this we reduces the need for crystalloids and also the risk of secondary coagulopathy. We reduces the need for blood products. In case of the need for a surgical intervention, we increases the visibility in case of, for example, suturing up a tear in the vaginal tract. And if the patient has become hypovolemic, we actually stabilize the patient by increasing the afterload when we compress aorta. So we will see that the blood pressure will increase and the cardiac rate will decrease, which is also very useful for me as an anesthesiologist in the time of inducing anesthesia for these patients when they are to have some surgery. So what is the evidence and what is the recommendation? We know the WHO recommendation for prevention and treatment of PPH. And here we can see several interventions mentioned, like the intrauterine balloon tamponade, urinary artery embolization, and bimanual uterine compression, and the external aortic compression. And what do they all have in common? They all have a weak recommendation and very low level of evidence. And as we know, discussed in the previous section, the level of evidence is low in a lot of the actions to be taken, not only in the management of PPH, but also in obstetric anesthesia in general. But what is interesting is that if we look a bit further in this guideline from the WHO, we find that they say external aortic compression has long been recommended as a potential life-saving technique, and mechanical compression of the aorta, if successful, slows blood loss. The GDG, which is the guideline development group, placed a high value on this procedure as a temporizing measure in the treatment of PPH. And that is how we use it. We use it as a to reduce the blood bleeding temporarily during transportation or while other procedures are taking place. What is interesting here is that they say has long been recommended, and I had to do some research because for how long time has this maneuver been recommended? I found this publication from 1835, which unfortunately is in France, and I don't speak French, but it talks about the external aortic compression. And I found another article. This is from a publication from 1937, and here it says, the first proposal of the kind was made, we believe, in 1797, when a writer in the largest journal spoke of passing up a hand into the uterus and then compressing the abdominal aorta. So that was the very first, was an internal, sort of internal external aortic compression. But then in 1823, they used the maneuver that we now use and teach by compressing through the abdominal wall. We also can find different, we can find this maneuver described in textbooks from, like this is from 1956, where we can see the maneuver described and different devices also for performing the maneuver. But it seems like it has gradually disappeared, that these manual maneuvers, they they sort of slipped away from our knowledge. And it was very interesting to see how Andrew pointed out the history in his first presentation, showing how all the uterotonics came in the 50s. And we know that the work of synthesizing oxytocin was awarded with the Nobel Prize in 1955. So my assumption is that this focus on medication is one of the reasons why these simple manual maneuvers after some time were forgotten. But what are the newer research and newer evidence? There are some publications in the 90s. I have chosen not to focus on them today, but Sultan is an obstetrician from Egypt. He has 3 publications about the use of external aortic compression. This first, from 2009, he tested out a device. He had 120 women in each group, all suffering from postpartum hemorrhage due to an atonic uterus, and they all received the traditional medication like uterotonics and other blood products and treatment, but in one of the group, they had also the use of external aortic compression. And what he found was that the use of uterotonic, each of the medications were reduced in the study group compared to the control group, and also the use of blood products. Like you can see here that in the study group, the group where they used external aortic compression, 51% did not receive any blood products, while in the control group, we can see that 48% received 3 to 4 units. In this publication from 2010, it is the same women as in the publication from 2009. But what he did here was that he also evaluated the blood flow in the femoral artery. And he could, in this publication, demonstrate that in the study group, the group where they had performed external aortic compression, the blood flow was significantly reduced. In this publication from 2011, he wanted to evaluate if there was any difference if the external aortic compression was performed with a device or with a manual maneuver. What he did was that he looked at all the years prior to intervention from 1999 till 2007. He looked at the number of deaths due to PPH, as you can see in the second column, and the number of morbidity and the number of severe shocks. And what you can see is that the year when they used the external aortic compression device was 2008. And here they had no deaths due to PPH and no patients with severe shock. And the same in the group where they used the manual maneuver. So he did not find any difference between the device and a manual maneuver. And you can see that he had a significantly reduction in morbidity and mortality. There is a publication also from Sweden where they evaluated the blood flow over the uterine artery using an ultrasound, and they found that the pulsation ceased when they performed external aortic compression. And they also did the same over the iliac external artery. So this is in Swedish, and you can probably not read it, those of you who are not familiar with the Scandinavian language, but this is the national guideline for how to manage PPH in Sweden. I have translated it so that you can see in English. What it shows is that a stepwise approach depending on the degree of bleeding, and you see all the actions underneath every step related to the degree of blood loss. But what you can see on the very top is a red arrow where it says always consider external aortic compression and uterine compression. And that was what I experienced as an anesthesiologist working in Sweden, that all the patients that I received in the OR, there was a midwife sitting in the bed performing external aortic compression in the elevator and in the corridor on the way to the OR. And it is interesting that the arrow starts in the very beginning, from when you have the diagnosis of PPH. I have also, this is a picture of the guideline at the hospital where I was working, and I have translated one part because the initial treatment in case of severe bleeding was external aortic compression prior to putting in an IV access, because they realized that if you stop the bleeding, we can monitor, we can do treatment, we can transport, and preventing further bleeding when we have reached a situation where we have a severe bleeding. So how do we perform external aortic compression? We stand on the side of the patient. We place a closed fist or the fingertips on the abdomen in the level of umbilicus. And we make sure that the thumb is outside to have an even surface on our fist. Slowly, we press the closed fist on the abdomen down towards the spine and continue to press towards the spine. The pulsation will be felt clearly on the side of the fist that is towards the woman's head, because we are increasing the afterload, we are increasing the blood pressure if we have a hypovolemic patient. It is important that we do a reposition of the fist if we continue to feel the pulsation in the femoral artery or the bleeding does not stop, because we know that columna is uneven and our fist is uneven, and we might need to do a reposition. So it's not only the force, but it is the way we perform it. What is important is that the location of the external compression point needs to be at the level of umbilicus because of the bifurcation of aorta. We know that that is about the level of the hips and the level of umbilicus, so that's why we aim for the umbilicus, but we always teach that you have to, of course, feel the aorta and adjust your position so that you feel aorta just below your fist. So what is the sign of a successful external aortic compression? The femoral pulse will stop. You will, if you have a vaginal bleeding that is visible, it will cease or be significantly reduced if you're not able to compress it completely. The blood pressure will increase and the pulse rate falls if you have the monitor on the patient, or you can even feel just a pulsation by in the radial artery. Some more additional information. External aortic compression can be performed independent of the cause of bleeding. It can be performed before placenta is expelled, and it can be performed during cesarean section. There is actually, if you look at clinical trial, there is one trial that is registered now, as in Sweden. They aim to include more than 2,000 patients after cesarean section, and immediately after the baby is born, they will perform external aortic compression in one group and not in the control group. And they want to evaluate if they can, the degree of bleeding in these two groups. So there is that is a major research. External aortic compression is dynamic because you will always want to evaluate if your treatment has succeeded. So you want to evaluate if it has stopped bleeding. That can be that you have sutured up a tear and you want to know if it is completely or if you need to do any more stitches. It could be to evaluate if uterus has contracted sufficiently and you want to evaluate if it has stopped bleeding. So it is very dynamic. And what we recommend is that you can keep it at least for 1 hour. What Sultan found in his study was that after 2 hours, the women felt a bit numbness and pain in their legs. and that disappeared as soon as they took off the device. So at least for 1 hour. All the maneuvers that we perform, they are painful, like just to evaluate the tone of a uterus is associated with discomfort for the woman, and also uterine massage and uterine compression by manual compression. All these maneuvers, and including external aortic compression as well, is painful. And that's why it is very important to inform the woman why we're doing it, and we inform her of the importance of the maneuver. It can be performed despite a high BMI, and it is not an invasive maneuver, so we have a lower risk for infection. It can be used during transportation, and what we do in the hospital is that we sit in the bed with the patient and perform the maneuver. It is, of course, difficult during transportation in an ambulance because you cannot stand in the ambulance and perform it and provide the sufficient pressure. So that is a challenge, and that is also why we want to develop a device. It does not require any medical training. In Ethiopia, we have been training the cleaning personnel. I just wanted to show you what has happened in my hospital. This is the incidence of severe bleeding of more than 1,500 milliliter or transfusion per 1,000 deliveries in Norway and in my hospital. We had the first training in March 2019. And what we see is that 2019, it started to drop. Then we have had a pandemic situation all over the world, so we have not had the chance to train in my hospital either. So I would suspect that we should have had a steeper decline in the incidence, but we're still working on this. The trainer that we developed allows the healthcare workers to practice the external aortic compression and also the uterine massage. On the very first prototype we developed, we had a training with the ambulance personnel, because in Norway, the people that work with lack of resources is the ambulance personnel. And they had not even heard about external aortic compression. They had no clue how to evaluate the tone of a uterus and how to experience the uterus contract. So this project was a part of a research and is published. We have been training healthcare workers all over Norway at several hospitals, and more hospitals are now implementing this maneuver. We have also tested out long distance training by sending the mannequin to nurses who work in remote places and are responsible for deliveries, but very seldom. So then we had a chance to train not by going there, because that would not be cost effective. We have also piloted in several countries and are now, and we are now doing one implementation project in Ethiopia and one in Brazil. I'll share a bit more about that in a second. Using our device, we wanted to evaluate the degree of blood loss. So we had 8 pigs with a median body weight of 61.5 kilogram. We put in 2 arterial lines, one in the brachial and one in the femoral artery. And we put in 1 exsanguination catheter in the contralateral femoral artery. We evaluated the spontaneous hemorrhage for 3 minutes through the exsanguination catheter. With the device mounted, we had the median brachial MAP was 112, and with the median femoral MAP was 30. So we had a compressed aorta. With our device, we were also able to evaluate the degree of pressure used, and we found the need of the median pressure that we used was 140 Newton, which is equal to 14 kilogram. And without the device, we had the median brachial pressure of 106 and median femoral pressure of 106. So no compression, totally even. So what we found was a reduction of bleeding with the use of EXAC compared to without. This is the milliliter of bleeding for 3 minutes. Each color represents 1 pig, so with and without external aortic compression. As you can see, we had a very thin exsanguination catheter in pig number 2 and number 3, so that's why they bled less than the rest of the group. We also wanted to evaluate the degree of contrast reaching below the compressed area. So we did computer tomography on these pigs, first without compression in picture 1A, and then we gave contrast, and we evaluated the degree of contrast that reached it below the area that we should compress, and we could see a time-intensive curve and calculate the degree of contrast that reached below the area. And then we did it in AB. You can see that we have a complete compression of aorta, and then we reduced the compression in the 2 next slides. And we were able to reduce, A1 was, we made it that our baseline, and in AB, we had only 0.33% of the contrast reaching the aorta trifurcation in the pigs. Very shortly about the implementation research in Ethiopia. We have now been teaching 258 healthcare workers at 4 different hospitals. We asked them prior to teach the training, we asked them, how do you evaluate your level of knowledge related to uterine massage? How do you evaluate your level of knowledge related to external aortic compression? How do you evaluate your ability to perform uterine massage? And how do you evaluate your ability to perform external aortic compression? I just want to point it out, here is the baseline, and here is directly after training. I just want to point it out, this regarding external aortic compression now, and prior to training, only 54 of the people we trained said that they had a high ability to perform external aortic compression, and after training, 224 of the 258 said that they had a high ability. We also asked them, what are the top 3 actions to perform if you have a patient that suffer from severe postpartum hemorrhage? And they were given a long list of actions. And prior to training, they said, call for help, put in IV access, and identify reason for bleeding. After the training, external aortic compression was action number 2 to be performed. This was done in November, and what we want to know now is to see if we actually have affected these actions in clinical work. So that will be evaluated 3 months after and 6 months after. And we are now, last week, we started a similar project in Brazil that will run over the next half year and further on. So, all over the world, we have 140 million deliveries every year. And the 70,000 that dies due to PPH is only the top of an iceberg. If we believe the Swedes, and I think they have good reason for have some good opinions in this, we should perform external aortic compression in about 14 million deliveries, because we know that about 10% suffer from a severe PPH. Thank you.
That's fantastic. Thank you so much, Greta. How interesting to see this method resuscitated. Is that it? And reinvigorated after, I think, for many of us, many years absence. I think I'm sure there's questions, and there's in fact some questions coming up, but I think we should probably move on because we've still got one talk to go. And maybe at the end, then we'll have time for questions. So, Josephat Byamugusha, Professor of Obs and Gynae at Malago in Kampala. Welcome very much to you, Josephat. You're going to tell us about rather than external aortic compression, internal aortic compression.
Yes,
Is that
yes.
INT-AC or REBOA as it's more commonly known? Josephat, over to you, please.
Thank you very much, Andrew. And it's good that this one is coming after the just concluded presentation, because for us, we are going directly into the aorta. And I've mentioned those few points about Uganda. What does it stand for? As you can see here, it is a resuscitative and endovascular balloon occlusion of the aorta. And it is directly placed in the aorta, basically to control the hemorrhage. The simplest way we can put it here, if, for example, we refer to trauma, is that once that hemorrhage is controlled, then it means that the lower part, the bleeding stops, and then there can be room for action, for warnings, for preparation. And as we shall see, if we come to the obstetrics, for example, in somebody who is very seriously bleeding, it means that if, for example, it is ruptured uterus, the bleeding can be stopped a little bit, and then there is room for preparation. And we'll continue to move. Where can it be used? It has been used mainly in the traumatic life-threatening hemorrhage, which is on the next slide. Traumatic threatening life hemorrhage. And now a few studies are coming up. There is a study which was done in Japan. It is published in 2022 by Kamijo. And it was published in the Journal of Trauma and Acute Care Surgery. And it was an observational study, and it is showing that much as previously REBOA has been used in trauma patients, it can now be used in obstetrics as well, in the areas where there is a lot of hemorrhage. And members, as you know, and those who are watching, that bleeding can be very bad, and even the surgery becomes difficult when the bleeding is covering the whole of the surgical site. Let's move to the next. I can't move them from here, and that's what I've just said, and we can continue. Yeah, now just a minute. The previous surgery, the previous slide, I want to mention something about it. Now, for many people have not been used a lot to interventional radiology, but the interventional radiologists can actually insert a cannula from the femoral vessels and go up to the level of the cerebral vessels and remove a clot. Meaning that actually for some people, interventional radiology has been done a lot. And somebody was describing how it happens in stroke. If they go with the cannula, they can remove a clot, and somebody who was unconscious starts talking and smiling, mainly through the part of interventional radiologists. We can continue. So it is quite an important area that some people have actually utilized quite well. Now, this is the balloon. This is what we are talking about, but this one has already been ballooned. That's why you see the center part is bigger than the rest of the other parts. Usually for the balloon itself, we put in about 10 mils of, usually can be saline or sterile water for injection, sterile water. And the dilatation here can range between 15 and 25 centimeters. And that is enough to occlude the aorta. Now, the other important part to note about this is that this occlusion should not be maintained for a long time. So it is very important to keep releasing the occlusion every 10 minutes and not exceeding 1 hour. Most of the literature gives between 40 minutes and not exceeding 1 hour, because if exceeding 1 hour, according to literature, has been associated with a lot of mortality. So we tend to have the occlusion for 10 minutes. The blood in the area of operation is clean, so one can do the surgery, then release a bit so that the tissues, the peripheral tissues, do not lose blood completely. Let's move to the next one. Well, there is something very, very important here, and it is called the Seldinga technique. Basically, most of the surgery done and where the interventional radiologists are coming, it is mainly about the Seldinga technique. It has got a few key points, this Seldinga technique, who was a Swedish radiologist. There is needle placement. The guide wire is inserted, as is shown in the pictures here. and then the needle is removed. Then the catheter is threaded in on the guide wire, and then finally the guide wire is removed. So these are principles, and they are the same principles that are applied in the REBOA as well. These are available for easy understanding. They can also be seen through pictures, which are readily available on the internet. But the Seldinga technique is what people now are applying in obstetrics as well. Let's move to the next one. Now, basically here it is trying to show what is included in the REBOA. If you look on the top right, we have there is the dilator, there is a sheath which I've just talked about. Then there is a French size of the cannula that we use. Currently, what we are planning to use here is French gauge number 4 for REBOA. Then there's a side tube and a mini guide wire. And the stopcock can be, there are several types, but for us here, for example, we have one way. And then you can see on the lower part, the balloon itself ballooned out. There have been several types. You can see that this one is a bit oblong, but the one I've just shown is a bit more round. So it has been undergoing modifications. And I can explain more on the next slide on what really goes on. Now, according to interventional radiology, there are 3 zones that the aorta can be put in. There is the aortic zone, where which ranges from the left subclavian, the celiac trunk, and you can see that well marked out according to this. And then there is the zone 2, which is from the celiac trunk, the lowest renal artery. Then we have aortic zone 3, which is the lowest, from the lowest renal artery part, the aortic bifurcation. Now, REBOA can be done zone 1 and zone 3, but for us, why we are focusing in regard especially to the obstetric complication, we are focusing more in the aortic zone 3, which is from the lowest renal artery to the aortic bifurcation. So we don't go beyond the renal arteries when we are inserting this cannula. So let's continue to the next one. So these zones are quite important to understand. The research which is available, which is basically what we have indicated, is that it is being used quite a lot. It is approved intervention as far as emergency medicine is concerned. And this is one of the studies, as you can see. The Houston formula is used for survival and widely recognized for predicting survival from sudden cardiac arrests. What you see here as an Austin-based case study. So they have used it a lot in trauma, in emergency. So now we are trying to bring it to obstetrics. Let's move to the next one. Now this slide has been put here for one big purpose, that previously they would do the REBOA under guidance, under fluoroscopy. But now the work done, you can see here, Knut is one of the people we are currently working with, is from Norway. And it has been shown that actually it can be done without using fluoroscopy. That becomes very important for us in the low to middle income countries, where we may not have the fluoroscopy readily available. Instead, what is used, you can go to the next one, is that a scan can be done. You can see here, this was training where it was simulation training. A scan can be done, put at the femoral vessel, so one can directly see the vessel, so that when the REBOA is being introduced, one can see where it is going. And that's currently what we are applying. And this was a training in Uganda here at Makerere University. The training was done at Women's Hospital. And some of you who may not know, I am the second left standing. Now, we thought we should share a little bit of the training as well, and we can move to the next slide. It has got 3 main parts. There is the indication for the procedure, preparing for the procedure, and performing the procedure. Because since this is coming out to be a useful study, as for example has been proved in Japan, it is likely that we may soon be taking it up. Here we are yet to do a clinical trial. We started with an observational part together with Professor Tokild from University of Bergen, and Knut Lea Lubulwa, and who is an anesthesiologist, and others. So you have REBOA. One has to obtain relevant medical history and physiological values. One has to talk about the decision, preparing the patient. These are all key, because remember, the procedure itself must be a sterile procedure. So there is a lot of infection prevention that is needed here. One is needed to have some proficiency in ultrasound imaging so that one can easily tell the vessels, aspect of intra-arterial cannulation, starting the guide wire, the introducer, the balloon. You realize that when you practice, it doesn't become as complicated as it appears here. Then once that is done, the introducer is fixed. Then there are these aspects. After that is done, there is inflation and deflation of the balloon, as I have indicated, every 10 minutes for deflation. Then at the end, once the procedure is done, there can be removal of the balloon. So a lot of cooperation is needed with the assistants. Communication is key as well. And this is basically, the occlusion should not exceed 10 minutes. We can move to the next. So this training can be done with time. Now, who can place REBOA is another one, because not everybody should really be able to do the REBOA, but it can be placed by a surgeon or an interventionist, that is like an interventional radiologist, responsible for different hemorrhage control, or by a physician trained and qualified in REBOA, in direct consultation with the doctors, who could in this case be obstetricians and gynecologists, so that they provide definite hemorrhage control, meaning that REBOA is done, but all the other aspects that have been discussed by my colleagues, by Justus, Weeks, and Grace, can be applied. The drugs, those continue. If it is, for example, to control hemorrhage, like for ruptured uterus, the other measures must be continuing as the REBOA is being applied. We can continue to the next one. I'm trying to take as little time as possible. Now, this one, wanted to bring it in. It is Cobra OS. This is one of the new ones that is being brought up. We actually have a sample here at Makerere and the Kawempe National Referral Hospital for French boards. Cobra OS means control of bleeding, resuscitation, arterial occlusion system. And you can see basically what it has is what we have just talked about, that is being used in the REBOA. Currently, this is the group that supplies. That part you see A there is very soft. It's harder than the rest of the parts, because this is the part that goes up. It is soft so that it does not cause injury to the organs. We can go to the next one. And you can see French gauge number 4 here, and that's good enough for use. Now, one observation we have made here, we see we have not said conclusions on observation. It is important that safety implementation of REBOA is established, especially through limited aortic balloon occlusion, the occlusion time, and a thorough balloon deflation regime. Like I have tried to emphasize that and as you know, blood supply can't be cut off for a long time on parts of the body. Let's move to the next one as I try to conclude. Now, this is the Kawempe National Referral Hospital, where the trial is going to be held, and but it is in line with the Center for International Research, University of Bergen, Groningen University Hospital. That's where Knut is based, and Makerere University. Me, I'm from Makerere University, and we have also a women's hospital, that is Mulago Specialized Women and Neonatal Hospital, where we do some of the training, and eventually we implement. So we are at a stage where we have got approval from Research and Ethics Committee, where we started with the baseline, just observation. Observational part was to see how the hemorrhage is handled and which cases are we likely to get. So that is like the baseline of the observation part. Then we are analyzing those results, which will be shared and published, and then we can now continue with the intervention, which is some people call a minimally invasive procedure that could be able, because you see that the fact that it goes direct to stop bleeding, stop blood supply, could actually support us much in the low to middle income countries to control hemorrhage, which has remained very dangerous, up to 42% of the maternal deaths according to the MPDSR reports that we have. I could stop here, and I'm actually here in the REBOA office with Claire Albudwa, who is an anesthesiologist, and the coordinator as well, Hade Narubama, and my other colleagues may be online as well. Thank you very much, colleagues, the viewers, and my colleagues over here. Thank you.
That's fascinating. Thank you, Josephat, and thank you to all the speakers. It's interesting how these two of stopping aortic blood flow are actually very similar and complementary, and the research into each will feed research into the other. We've just got over 5 minutes for questions. We've got. Let me just pick out one which came up actually about. I think it's about aortic compression, but it also relates also to the REBOA technique. Are there any contraindications, and are there any after effects of this procedure? It's interesting how the two differ slightly and how long you would persist with it. And I guess if you're talking about an arterial embolism, if you've got a blocked femoral artery from an embolism, I think they talk of 6 hours, don't they, to save the limb? Whereas actually we're bringing it right back from that, aren't we? We're bringing it an hour with aortic compression, or even just 10 minutes for the REBOA before you release it and allow some blood flow to flow to the lower limbs. Any thoughts either of you want to answer out contraindications or any after effects that people have seen?
Yes, I can comment on that. We have not seen any after effect clinically, or I have not even read anything. I not found any articles about that. Regarding the pressure needed when we do this externally, we have to think about that every time we even measure a blood pressure with a non-invasive monitor, we compress the arteries. And if we do surgery, orthopedic surgery, we put on a tourniquet that also provides a huge pressure on the vessels. So that is something that our vessels are kind of familiar with. What we did in our pig study was that we maintained pressure for 1 hour. And then we had a complete compression of aorta for 1 hour. And we did an autopsy afterwards, and we could not find any harm on aorta. We could not find anything that we had provided or caused. Neither on aorta or on the intestines that we press as well. We have to also remember that when we compress aorta after delivery, the abdominal wall parts during pregnancy, the muscles parts, so we have very easily access to both the uterus and aorta, and we are quite familiar with assessing the tone of the uterus and familiar with that region, but we kind of, it seems like that stops when it comes to aorta, but it's very easily accessible, and it does not require a lot of force to compress aorta when the muscles are parted.
Thanks, Greta. Josephat, in the REBOA, you're talking about finishing for 10 minutes. You implied that there was some problem with doing it beyond that?
Yes, because you want thank you, Andrew. You want intermittent blood supply to especially the peripheries, so that it's not cut off. And as you know, we have a limit, because the moment the REBOA is started, then the blood supply is totally cut off. There has been some literature that the vessels can supply some blood, the other side blood vessels, as I can call them. But it's not advisable to go beyond 10 minutes and not beyond 1 hour. Literature indicates that could lead to increased mortality. But there is that part that they talked about contraindications, or where we should not apply it. we do not want to apply it when the baby is still in utero. So it is only applied when after delivery. Because as you can see, if that is done, then to cut off blood supply. So somebody should not attempt. It is even, even practically very difficult to apply it when the mother is still pregnant. So it should be reserved for postpartum. And that's a contraindication.
Yeah, thank you, Josephat. I mean, indeed, you can imagine why even there's a difference between the two, because aortic compression externally maybe isn't complete. You're still allowing, there's probably some blood coming through intermittently, whereas really with the REBOA, that's you really are putting a complete block on it, aren't you? Josephat, can you just explain for people who aren't familiar with it? You talked about the three regions, or the three zones, sorry, zone 1, 2, and 3. And clearly you don't want to be putting it up near the renal arteries. How are you ensuring that it reaches zone 3 and not higher up? How can you be confident with that?
Yeah, I have one of them here, and it's of course very difficult to see, but it has got marks. The wire itself has got marks on how far one can go. Let me see whether there is one like here, and if I move it a little bit, there is another one here. So basically,
just
this
move
first
it
one.
outside, Josephat. We can see your hand, but not the.
Yeah. So this, and I can show all of it like this. It's quite. This is a sample.
Okay.
So the part near the end, you can see like this, the way it is.
So
that
those are markings on it.
Yeah, that means that one would have gone higher up.
Okay.
Yeah, zone 1. Now, as you continue, the second one is the one which goes up to zone 3, and that's our target. So the smaller part goes, the shorter part is the one which goes up to zone 3. So meaning that it can be regulated. It's not like it is unguided. There has been an attempt to do that, and that is really on the piece that is provided. So that's how we know and minimize injuries to the blood vessel.
Fantastic. Well, thank you so much.
Andrew, you muted yourself.
You would have thought with 3 years of COVID and of constant Zoom, we would have learned how to unmute, but it still doesn't seem to stick. Thank you so much, everybody, for this fascinating session. I'm afraid our time has come. We could talk about this for the rest of the day, I'm sure, but I'm sure all the speakers would be happy to, if people contacted them offline. There's been some interesting discussions in the question and answer and chat box. But it remains for me to close the session. Thanking very much Justus and Greta and Josephat for 3 fascinating talks and interesting discussions. And if people have got topics that they want to talk about in the future, or they'd like to see us address through the community of practice, this is your forum in a sense. This is a chance for everyone to discuss good practice, problems that they're having. How do you implement all these issues are right for us to talk about. The next time we're doing a webinar is on Friday, the 14th of July. So that's what, exactly three weeks today, something like that, Sherry? 3 weeks today, and we're going to be talking about the emotive study, which people may have seen published a few weeks ago, which talks about, it's a first-line bundle of care for treatment of postpartum hemorrhage. And we're going to have a session devoted to that. So thank you very much. Thank you, Sherry, for all your help in organising it. And that's us to say goodbye, good morning, good afternoon, good night, wherever you are in the world.
Thank you.
Thank you very much.